Even though Anwar's DALK technique was published in 2002, it presents several technical difficulties in understanding what's going on inside the corneal tissue during the injection. This technique has many advantages over PK. The most important is the preservation of a healthy endothelium. This translates into less endothelial cell decay and avoids endothelium rejection. These charts, presented by Born in 2001, demonstrate long-term endothelial cell loss. In comparison, DALK technique has a small decay over the first month post-op, and later on it behaves as a non-transplanted endothelium. This technique presents many challenges to the surgeon, and even if it looks easy to perform, it is not a piece of cake. Several modifications to the original technique have been introduced to simplify the procedure. Some of them are: the trephination is performed superficially, not more than 50% of the total thickness. We check the depth of the trephination with an iris hook. The first keratectomy is then performed superficially and previous to the air injection. This gives us a better control over the plane we want to inject the air. It is imperative to bend the needle bevel down. The eye of the needle looks at the eye of the patient. The air should be injected in a gently manner. When the big bubble forms correctly and it is evident to the naked eye, we can see the following signs: protrusion, white halo, waving, silver reflex, and hypertension on the apex. Here we can see a full moon sign as described in the video presented at the 2020's ASCRS Film Festival. Sometimes we need several air injections to achieve a complete big bubble. An important tip is to always inject in a wide emphysematous area, since it is a thicker area because of the expansion created by the air. We now have a new tool to assess the complete formation of the bubble: the corneal transillumination. This can be easily done with a vitrectomy light probe, as we can see in these images. In this particular case, we were forced to inject air several times in order to achieve the desired size. It is useful to mark the border of the bubble with the aid of the transillumination to inject air from that side without risk of perforating. The type 1 bubble should not be larger than 8.25 mm diameter. When do we use corneal transillumination? This technique is ideal to use when we can't see the big bubble under a complete white emphysematous cornea, like in this case where we can see the light bouncing inside the bubble due to light reflection. We can clearly see the full moon sign. Also, after a superficial keratectomy, knowing that the bubble is formed and present, to check for any air loss. This keratectomy allows us to easily remove the remnant stroma over the pre-dual layer once the bubble has been deroofed. Lastly, the transillumination helps us when the bubble is small and we need to expand it. Once the big bubble is created with the appropriate size, we strongly recommend creating a paracentesis in order to decompress the anterior chamber. This avoids inducing iris ischemia due to the elevation of the aqueous humor pressure. Always create the incision far away from the bubble to avoid puncturing it. The slash maneuver is performed with a 15 degrees blade. To create the petals, always use blunt scissors. Another nice tip is to dissect with the Barraker spatula any fibers remaining between the dual layer and the remnant stroma. All the previous tips apply when the big bubble is formed, but what happens when we can't achieve an adequate type 1 big bubble? Do we convert to PK? Do we continue? When do we say enough is enough? This is a typical case where we can't create the bubble. Transillumination indicates the absence of the bubble. So when we can't create a big bubble, what we recommend is to continue with an air injection and keratectomy sequence until we run out of space in the stromal bed to place the needle without puncturing into the anterior chamber. This is called manual DALK. How do we reach the correct plane? Without the aid of the big bubble, we have to decide what plane to dissect. We first perform a vertical incision in search of a dark line or zone representing a very thin layer above the decimate layer. The thinner the remaining layer, the better visual acuity post-op. As with the big bubble, we strongly recommend draining the aqueous humor through a paracentesis to avoid perforation, since there's less chance to perforate a hypotonic cornea. We continue with a manual delamination with a crescent knife until we reach a plane over the duos layer. This step has to be done gently to avoid puncturing. For the final layer, we recommend the use of faux glass dissector, since this is a blunt tool. This technique has the steepest learning curve with a high rate of perforation, but we strongly recommend trying it instead of converting into a PK. The following flowchart shows our DALK decision-making process. The chart exemplifies the different situations that we can encounter and how to solve them. If you don't obtain an evident type 1 big bubble, there are three main options that can happen: no bubble, small bubble, or type 2 bubble. When you don't achieve a bubble, you will have to inject more air until you succeed. If the bubble is small, again, you will need to add more air to expand it. If you still don't obtain a bubble, you will have to continue with a manual technique, layer by layer. And finally, if you get a type 2 bubble, you will need to perform a manual technique as well. So in conclusion, here are some tips. Partial trephination, superficial keratectomy, inject air in the thicker area, use corneal transillumination in every step, paracentesis and decompression after big bubble or working on the deepest layer in manual DALK. Always use blunt instruments like the faux glass dissector. Dissect peripheral fibers between the duos layer and the stroma with the Barracuda spatula, pushing the stromal side. In manual technique, vertical incision, and find the dark line. All these tips will make your DALK a little bit easier, mostly if you are beginning with this procedure.